Good. Okay, so once you've transitioned to compression garments, you're going to transition the person to a home program where they're doing their own exercises. They might be doing their own self-massage and they're wearing compression garments. This is one of the hardest things for people to do because they have to don and doff their compression garments, and they're very hard to get on and to take off. And so you have to be thinking outside the box on what people can do for their long-term compression. Another option out there is the pneumatic pump. I don't get these for everybody. The school that I went to actually did not believe in pumps. They felt that they did not remove the protein from the extremity, but sometimes they are a necessary option. I like to use them for my people that work full-time and they need to be able to use a pump at home in the evening because they don't have time to be able to come into the clinic all the time. Now, Medicare will pay for a pump if the person has had at least 4 weeks of conservative treatment, and some insurances will pay for them. Training and certification. There are several schools of lymphatic therapy to become a certified lymphedema therapist. They're pretty extensive and they're pretty expensive. So you would need to create or attend a program that's similar to this one from Norton. Norton is the school that I attended, but all of them require about the same amount of work. And so this program requires 45 hours of home study and 90 hours of classroom instruction. So the 45 hours of home study you complete before you go to the program, and then you go to the class, which the class hours were from 8 a.m. to 7 p.m. They were very long days. And you do both lecture and lab during the class, and then you have to test out with both the lab and a written test. As far as just getting trained, you can have if you have an occupational therapist who is certified, they can train you to do treatment, and you wouldn't be certified, but you'd be trained to complete the treatment sessions. That's actually how I started. I was trained over a 2-day course session with an occupational therapist who was certified, and then eventually I went to the full certification course. Frequently, facilities will pay for this course because they want someone certified on their staff. So you can see the course cost on this site is $3,200. But when I went, my hospital paid for that. They paid for the hotel room and they paid for the flight and all my food because they wanted someone certified. So the role of the occupational therapy assistant. The occupational therapy assistant can play a huge role in the treatment of lymphedema patients because they require a lot of time on the schedule. Typically, I see my patients who are doing the full treatment session with the bandaging, the massage, the exercise, everything. I see them 3 times a week, typically Monday, Wednesday, and Friday, and I see them for anywhere between an hour to an hour and a half at a time. So it's a very long session and it really takes up a lot of my schedule time. So the occupational therapy assistant could do those treatment times, and where the OT would do the evaluation, the progress report, and the discharge, and then the day-to-day management would be covered by the occupational therapy assistant. In fact, one of the CODAs I used to work with down in Hebron, she has gotten certified because her occupational therapist was certified, and so then they can share those patients and treat them. Most sessions start out an hour and a half, and sometimes they can be 2 hours, depending on if you're bandaging 2 legs. And then they get shorter once you transition into wearing garments of some sort and are no longer doing the bandaging. Some of the challenges and considerations, cost and insurance coverage, because it's a lot of therapy. You know, if you think someone is coming in for an hour and a half to 2 hours 3 times a week, and the school actually recommended daily treatment, but that doesn't work with our insurance coverage at this day and age. But so you need to take into consideration the person's insurance coverage, their cost, Compliance is huge. So my first evaluation with a patient, I explain everything that we're going to do, and I make sure I have buy-in, because some people do not want to do this treatment because of the bandaging component. And so because they have to wear that till they see me the next time. So I might bandage them on a Monday, they come in on a Wednesday, and we remove those bandages and we do the full massage, rebandaging, and then they exercise. So they have to cover that extremity to bathe, or they have to sponge bathe. And sometimes people are not willing to do that. But once I have buy-in, then I get them on the schedule. You have to have the ability to don and doff a compression garment or have someone who can help you. That is probably one of the biggest barriers, second only to cost. So a lot of my people cannot do this. They cannot take off a compression garment and put them on. So that's a lot of it, is figuring out how they're going to don and doff that garment and what garment's going to work for them. And cost comes into play too, because Medicare will not pay for a compression garment. And a lot of my people are on a fixed income and they cannot afford it. So then you have to find an alternative. Also, balance. If someone has poor balance, I typically won't wrap their lower extremities, because that's going to take away from their balance, and they may have a fall. In fact, I had a patient who had a fall. She'd had a total knee surgery, and we were treating her lymphedema, and she had a fall at home, and she had to have surgery on her knee. She didn't fall because of the bandages. She fell for other reasons, but you have to think about that when you're deciding whether or not to bandage someone. The person's lifestyle, do they have to go to work, or they live alone? Are they a gardener? I have a lady right now, she's a breast cancer survivor. She gardens, she sews, she does all these different things. Well, if I bandage her up, then she can't do a lot of those things, just because you don't want the bandages to get dirty. And so you have to take their lifestyle into consideration. Wounds are the other key thing that you will have to treat if you're a lymphedema therapist. So people with chronic venous insufficiency frequently have non-healing wounds in their legs. And so you have to be able to treat those wounds. And if you're going to be a lymphedema therapist, I recommend taking a wound course. And I will tell you, wound treatment is not for everyone. It is, it's difficult, and you have to coordinate with nursing for dressing changes. Frequently, I just do the dressing changes myself. I have the person bring their wound supplies in with them. The neat thing, though, is a lot of times these wounds that won't heal will heal once you start bandaging the person. I had a gentleman who came in, and he'd had a wound for 10 years. He'd seen vascular, he'd seen surgeons, he'd seen all these people, and he told me, "You're not going to heal that wound." And I said, "Yes, I am." And we healed that wound. And he said, "I would have never have guessed it. But once you get that edema out of there, then your body can heal." And then the other thing to consider is just the psychosocial piece for your cancer survivors. A lot of my breast cancer survivors, they go through all this treatment and have all these doctors in their lives and chemo and radiation. And then once they are done, then everything stops, and they don't have that support system anymore, and they don't know how to live, and so there's a lot of psychosocial. We do a lot of that type of therapy during the massage portion. And that is an area that I definitely want to pursue, is providing more support for my cancer survivors. So the next thing I'm going to do is a demonstration of bandaging on Farah's leg and show you a couple of the compression garments that are out there. The manual treatment is something that you have to feel to understand. It's a very beneficial manual treatment for any type of swelling, even your upper extremity injuries and surgeries. I use some of these treatment techniques for my hand patients too, but I am going to demonstrate that bandaging for you so you can see how cumbersome and extensive it is. So,
okay.
Okay, now we're going to do the bandaging portion of treatment. This is in phase 1. Typically, you bandage someone for 2 weeks, maybe 3, depending on how severe their swelling is. We're pretending that Farah does not have pants on. Because typically I have people put on a gown and get down to their underwear, and I put a blanket on them, and I have them on a high-low table. And I'm going to have her pull her foot up so it's like 90 degrees. And I just use this cotton wrap to pad her foot a little bit. And some people just use this cotton wrap and don't use the foam. The foam is more comfortable but more bulky. I use both, it depends. And this wrap's going to be a little bit big for her foot, but we're going to just make do. Now normally I would wrap her toes with this little one, but I'm not going to do that today. So the foam helps break up fibrotic tissue in the extremity, and it also helps create a gradient so that your leg is shaped like a cone. You want it to be more cylindrical when you wrap. And they have little names for everything, like the Roman sandal is what I'm doing right now. You have to have the right amount of pressure and not have any wrinkles in your wraps, but you learn all of this when you have the training and you do it over and over and over, so you usually have it by the time you leave.
It's comfortable, it feels cushiony.
One of the things they made us do was wrap our leg, and we had to wear it all day.
Oh.
Just during the class, just so we knew how it felt. And we don't use the little hooks that come with the wraps. We use tape. You don't want to nick someone's skin. Now by short stretch, you can see when I stretch this, it doesn't stretch very far. Now if this was an ace bandage, I could stretch it clear up here, and you do not want to use an ace bandage. So this one is a little mantra, and I always say it to myself: heel, ankle, sole. So I do the heel, I do the ankle, I do the sole of the foot. Heel, ankle. Oh, you know what I forgot to do is her leg. I'm gonna undo that. I didn't put the foam on her leg yet. What happens when they're talking and not actually treating? And this is going to be a little bit big on her. A little bit big. Now I would cut this foam to fit her better if we were doing this for real. And that foam helps to break up that fibrotic tissue that people get when they have lymphedema, which is kind of that hard, boggy swelling that you feel. All right, we will resume. So now we're doing the heel, ankle, sole. And if I was in the clinic, I probably would have picked a smaller bandage for her foot because she has tiny feet, but and And then we just continue up the leg, and you're trying to keep everything pretty even. It almost is like having a cast on your leg. And that's how I describe it to my patients. I tell them it's going to be like you're wearing a cast. So their shoes won't fit, and typically you have to put them in like a cast shoe. So I'll give them a cast shoe, and now I'm going to do like a figure 8 bandage. It's a firmer wrap, and not everyone can tolerate that. But for the people who can tolerate it, it's kind of more aggressive and gets that swelling out of there better.
That's cool. I can definitely feel a difference.
Yeah, and I'll make you walk in it too. Now I always make my patients walk to make sure they can walk, because sometimes you wonder if they're going to be able to walk. Plus I make them work an ankle crease in. I usually have them ride an exercise bike so that they get that repetitive muscle pump going. Now, if she had swelling all the way up, I'd have her stand, and I would do her knee and her thigh too. For my chronic venous insufficiency people, I only do their lower leg. And some of my people with poor mobility, I don't necessarily do their thigh either.
So if a CODA were seeing a patient that had this wrap on, they would still want to encourage the patient to do all the normal mobility that they would normally do.
Yes.
Stand up,
Yeah.
use it.
You want them to exercise.
All of that just as normal.
So as your muscles pump, they push against those vessel walls. Those vessels push against this, and that fluid goes up. So you want the person walking or biking or whatever they do. And actually, if a CODA was seeing this person, they would do this wrap. They would do the massage, they would do the wrap, they would take them out and do the exercise. They would do all of it. So on the other leg, I'm going to show some other options for compression garments. This one is called a circade wrap, and I use these all the time with chronic venous insufficiency people. Because when you have chronic venous insufficiency, your problem is here to here. So when you see these people with big legs here, and their legs are kind of brown or dark red, that is chronic venous insufficiency. That's some staining from the leaky blood vessels. And these are the best wraps for those people. So I get these frequently. It comes with, depending on, they've come out with a new liner, which I like much more. The old ones had a compression anklet that would stop about here, and then this would be just a cotton liner. Now they've made it one piece where there's compression in the foot piece, and then there's no compression in this. This is just cotton. So we're going to do this leg. Now, I'm not going to actually put this on her because she's got pants on, but I would put this sock on her first. And this has compression in the foot, no compression here. And you can also get a wrap that goes for the foot. I don't get that very often because it's awkward and it comes off and people don't like it. So I would put this on her, and then we would do the wrap. I'm going to be dirty again. And it tells you top, that goes behind the knee. And of course, putting these on by yourself is a little harder than having someone do it for you. And what I always tell them is just get it on your leg to start with. Who cares if there's wrinkles? Who cares if it's not on right? And then you go back and you double stretch. And these things were created to simulate these bandages. And most of my people actually really like these. Now, and what I tell my patients is if you're an obsessive person, which some people are, you can actually measure how much compression that you are applying with this card. So you take the arrow, you line it up, you say, oh, wow, that's a little too much. So I'm going to take it down.
Oh, cool. Yeah.
say black, and maybe I want it there all the way down. The other place that this comes in handy is in the nursing home or home health, where you're going to have CNAs.
So I don't know if you guys can see that on here, but these are the marks. And then she's measuring it up there. And
So I line that with this line, and then based on whether it falls in the white, black, or pink, it shows you whether it's 20 millimeters mercury, 30, 40, or 50.
and the tighter she pulls it,
Yeah, so I can completely stretch outside of it, or I can shrink it back. So if you're going to have a caregiver who's doing it,
yeah,
especially if it's a CNA,
mm-hmm.
you tell them exactly what they're supposed to do. Plus train them. Now for my people at home, if they don't want to use that card, I tell them to go on comfort. If it feels too tight, it's too tight. If it feels too loose, it's too loose.
Yeah.
And do that double pull. Yeah. And these work great for that. And then we're going to do an arm here.
Feel the pressure and feels like it's doing something.
They're easy.
Yeah.
They're not as hard to put on as a compression sock. And most people like them.
And you can still put a shoe on.
You can still put a shoe on. Yes. So what I'll do is someone comes in, they have a wound on their leg, and I'll start with this to break up that fibrotic tissue and get that fluid out of there, and then we'll transition to this for long term. Or I have a gentleman right now, he has a wound on his leg, he has mobility issues, and we ordered this right away. We got it in, and we did this for like maybe 1 week, and then we switched to this because now he can wear his shoe. I'm not worried he's gonna fall. Mm-hmm. And his wound's already healed. I've only been seeing him for like 3 weeks. So
what's typical for the wrap? How long?
2 weeks usually. 2 weeks, unless somebody's really severe, and then you can go 3 or 4, depending on what your goals are. So the gentleman I have right now, he's older, and with the virus going on, I want him not coming into the hospital. So my goal for him is get his wound healed and get him home. Yeah. And he was in Monday to see me, and his wound was healed. And so I was going to see one more time just to make sure, and then put him on a home program. But typically 2 to 3 weeks with this, and then you transition to this. I've learned through experience that day 1 or week 1, I'm ordering whatever we're going to use. Mm-hmm. So that when it comes time to transition, I have it. And if you have like Medicaid or something that's paying for it, sometimes it takes a while to get it approved.
And how often do you rewrap this within that 2 weeks?
You're supposed to do it every day, but that doesn't work. So I do Monday, Wednesday, Friday. And if someone tells me they can't come in that often, then I don't bandage them. I don't like to go more than 2 days with this on, because you don't know what's going on underneath there. And if they're rubbing or they have a pressure area and you don't know it, you leave it for 3 days, then you have a problem.
Yeah. And it's not worth it if it's not going to be consistent. And
yes,
why even do this for 2 days if it's not?
I had a lady that came in, she was morbidly obese. She had chronic wounds in her legs, chronic venous insufficiency. She did not drive herself. She had to have a family member bring her. She said, I cannot come in for therapy, but yet the wound clinic wanted her doing something. So I ordered her these. I got her the pneumatic pump for home, and educated her and her caregiver, and they're doing the whole program at home using a pump and the wraps. And hopefully that will keep her out of the wound clinic. Yeah, that's the goal. And then an arm sleeve. So this is an arm sleeve donor. One of the biggest barriers is being able to put this stuff on. So people really struggle. So sometimes I can't get them what I want to get them because they can't put it on. Or they don't have the money to pay for it, and insurance doesn't cover it. So this thing, I put it in. I can do it either like this way, and through, and then pull up. Saves a little grief.
Yeah.
Which
So
this one is
that's-
way too long for me,
But it's, I mean, it's tight.
but.
It's real tight. So she would be really yanking the try to get that in.
Yes, and then you get all the wrinkles out, which this one is way too long for me, but. And then typically I get it with silicone on top so it doesn't slide down. And then the other way is to use a desk and put it on like that. Then obviously you have your compression socks that everybody's familiar with. Typically, this one doesn't have an open toe, but I like an open toe sock because then you can use something like this over the foot. And then you put the sock on over that and it just slides
That's amazing.
so much easier.
You guys will see. We'll let you touch these when you actually get here, but these are very tight and hard to get on a patient. Because they're meant to be compression and they're meant to squeeze tight. So getting those on someone is very difficult. So this is genius because it's super slippery. It's almost like that parachute material. I think she
Yes.
said it was made out of jackets, like windbreaker jackets from the 90s.
So this one was made by one of my patients. She's creative. She made it red, white, and blue. One of them, she even put her initials on it. But when you order socks from like Juzo, that company, and you order open toe socks, so this would be open at the end, they will send you a paper version of this, which works just as good.
Paper.
It's kind of a paper that's got kind of a reinforced wax or something on the other side so it doesn't fall apart on you. Or you'll see people in the hospital, they'll use a trash bag.
Yeah.
Trash bag over the foot to help it slide because your TED hose are open at the toe also when your hip and knee patients can benefit from these too because it's open at the toe and it just makes it slide on your foot so much better.
Yep. And then the hole just pull it up.
Yep, and then you just pull it out the end of the sock. So, and then you guys will probably go over sock aids, and this one isn't used very frequently, but it's cheaper than the arm one. So sometimes I use this to don an arm sleeve because it's half the price, but you use it the same way. But you can also use it to put on a sock, but most people don't have enough mobility to use it to put on a sock.
Yeah.
They like the ones with the handle. And, yeah. So that's just sleeves. This, you will run into this somewhere. This is edema wear. It comes in small, medium, and large. This is a medium. The yellow stripe is a medium. This is just a cut piece. You'll see it in the hospitals. This is what I use if somebody has no funding and they can't buy, the wrap or the actual compression socks. I have this at the hospital and I can issue it to them. So this is what I use, or this is easier to put on than a compression sock too. So you can use this on the foot, you can use it on the arm, you can use the little slippy thing with it to put it on. And the small is supposed to be for the arm, this is supposed to be for the lower leg, and the large is supposed to be for the thigh. And you can get these usually at a drugstore too. But I use this a lot when nobody has funding. So, and it works pretty good. So, all right, that's it.
All right, very good.